So our next speaker is Dr. Ghabril, and it's Mawan Ghabril, and he's a transplant hepatologist at Indiana University. He was actually here the basement level in 2015, and we brought him back because he did such a tremendous job talking on something a little bit different. But he's really a distinguished clinician scientist, and he has interest in advanced liver disease. And again, he's just a perfect fit for this conference, as he is a true patient advocate. He gets many teaching awards, at least with residents and fellows, and so we all strive to be like him. He's going to be talking an AIH foundational talk as well, looking at current treatment approach in autoimmune hepatitis. Thank you, Dr. Ghabril. That's great. Either way, that's good. Can everyone hear me okay? All right. So I have no disclosures, guys, and thank you all for being here. It's a real pleasure to be with you. So the aims of my talk really are just to kind of go through an overview of an approach to treatment of autoimmune hepatitis. Many of you know this firsthand, so it's going to sound like old information. But I'm hoping to give you an idea of how varied autoimmune hepatitis really is. And on a case-by-case basis, there's just tremendous heterogeneity, which is, variability in the situations one might be dealing with and the ways to approach it. But sort of targeting certain points, we'll discuss what are the goals of therapy, when to treat autoimmune hepatitis, monitoring disease activity, commonly and less commonly used drugs for treatment, side effects of those medications, and finally managing the risks of therapy. So when we really think about autoimmune hepatitis and we think about the goals of therapy, the main issue for us is really trying to control the inflammation, because the root of all trouble in the liver is in fact the inflammation. So that's really mission number one, particularly at presentation when there's usually a lot of inflammation. That's usually how it comes to light. It's the inflammation that results in the presentation one way or the other, whether it's abnormal liver enzymes or symptomatic disease. So inflammation control and obtaining a remission, complete control of inflammation is really the main goal of treatment immediately and in the long run. But there's also additional concerns, which is trying to prevent the long-term sequelae of this chronic condition, which is the concern for progressive scarring of the liver, which could lead to cirrhosis. And it's really the cirrhosis, for the most part, that leads to morbidity and mortality in autoimmune hepatitis and other chronic liver diseases for that matter as well. In addition to this, we want to reduce and prevent the unwanted side effects of medicines, which oftentimes are lifelong or used indefinitely. So that's another mission statement. And finally, because of the complexity of care and the variability from case to case, we really have to strike a balance and truly personalize our approach in terms of treatment, monitoring, on a case-by-case basis. So it's really a highly personalized approach, pretty much in every case that I've ever seen. When do we treat autoimmune hepatitis? There are some guidelines. There are some USA and there are some European guidelines, both published in the last 7 years or so. They really speak to very similar criteria. And the criteria are when it's bad, treat. That's really what it boils down to. But what I'll show you here, let me see if... So if you look up here, so what we've got, the clearly indicated treatment is when the transaminases, or AST is what they selected, is more than 10 times upper limit of normal, i.e. a severe hepatitis biochemically, go ahead and treat. If the AST is moderately or modestly increased, more than 5 times upper limit of normal, and the IgG level is also increased. This is a protein that's produced in response to inflammation, particularly in the setting of autoimmune hepatitis. And so is another indicator of disease activity. So this combination would also indicate treatment. And also liver biopsy, even in the absence of liver enzymes or IgG elevation, if it shows severe injury, particularly with a type of autoimmune hepatitis where there's massive necrosis. This is a lot of cell death in the liver when you look at a biopsy, is also a very strong indication, as well as when the symptoms of the hepatitis are quite incapacitating. Relative indication to treat is really anything short of mild or quiescent disease and severe disease. And it really typically reads into some abnormalities in the liver enzymes, some symptoms, some inflammation, particularly interface hepatitis. And Dr. Cummings may have touched on this during his talk. And that requires a liver biopsy, by the way. And then finally, no treatment, and I would sort of add in brackets a caveat to that. I would say no immediate need for treatment. That doesn't necessarily absolve us of needing to worry about someone with these findings over the long run. We do have to monitor, but no immediate need for treatment is when the enzymes are normal, the IgG is normal or near normal, and the liver biopsy shows inactive disease, whether there's cirrhosis or not. So in terms of monitoring autoimmune hepatitis, what are we really trying to monitor? Well, it's inflammation largely, but of course also the scarring. What are the available tools, and how closely do we follow patients? So if we tackle these questions one by one and look at the things we're trying to monitor, again, liver inflammation is the key. And liver fibrosis or scarring is also important because we want to monitor patients, make sure they're not progressing with scarring and on their way to develop cirrhosis over time. So for liver inflammation, we have some tools, and probably the most frequently used tools are our liver tests, our liver enzymes. So these are the AST, ALT, and the bilirubin. And these are probably performed quite frequently. Less frequent blood tests include this immunoglobulin G that we had talked about. And probably least frequently, but also very important, is histology, the need to really look at the liver with a liver biopsy. And this is not only extremely helpful in making a diagnosis of the condition, but also in helping us establish that we've achieved complete remission, and also can help us with triaging the decision to withdraw care in someone who's been in remission for a while. So histology, of course, we can't do biopsies as frequently as labs, but they are important. And in terms of liver fibrosis or liver scarring, a key point there is that it typically takes a long time to develop. That's not to say that people can't have advanced liver scarring with AIH or cirrhosis. In fact, about a third of patients, and in some subgroups, almost 80% of patients may have cirrhosis at the time that they're diagnosed. But the key piece here is if you don't have cirrhosis already at diagnosis, you really do want to monitor whether you are developing increasing scarring over time, because you may modify how you're treating the condition and be more aggressive in trying to suppress the immune system. So in those that don't have cirrhosis at diagnosis, this process takes years. It's not a fast process, provided it's being treated. So untreated autoimmune hepatitis flaring can progress pretty fast, but I would say our non-severe cases, if we're treating, really should slow this process down. And in terms of blood tests, there are no accurate blood tests, although there are some characteristic lab findings that we find in patients that have cirrhosis. But we usually have to go to something a little bit more liver-directed, and there are some non-invasive tests. I think a number of you have performed some FibroScans, and Dr. Vupalanchi is going to talk to you about this tomorrow. There's also MRI techniques to get at the same idea of how much stiffness there is to the liver. But the gold standard is a liver biopsy, although increasingly with better technology, with FibroScan and MRE, assessing fibrosis is becoming much less of a driver for performing serial liver biopsies. And in terms of how closely we monitor the labs, it really depends. In an acute situation where there's severe hepatitis, there's a flare, you're probably going to want to look at the liver enzymes more frequently. In someone who's already settling down and going into remission, you could probably ease off on the lab frequency. Someone who's been doing really well in remission for quite a while, you could back down a little bit more. Notice I'm not giving you any frequency in terms of hard times because it's variable. Every physician and every patient have to decide together what's doable and what's reasonable. But I think in general, you could slow down a little bit if you're doing well. The longer you're doing well, the less frequently you could do the labs. And that's really sort of what that line gets to. But really importantly, all autoimmune hepatitis requires monitoring. So I would say there's never a period of time where you're okay not to be monitored. We always need to stay on it with some kind of monitoring. And it's got to be more than an annual, in my opinion, although that's probably something that can be discussed and different physicians will have different ideas. In terms of considerations of treatment, I bring this slide up just to kind of, again, highlight the complexity and variability in autoimmune hepatitis. So it can present at different degrees of severity. People can present with fulminant liver failure and need a liver transplant right away. It can show up as a mild abnormality in liver tests that someone chases down and we find it, and everything in between. It can present at different age groups. The course is not predictable. even the targets of treatment can be different from person to person. And so that's one. In terms of the medicines, well, there's a number of them. Their potency is variable. Their side effects and costs are also different. So another realm for customization and variability. And there's also underlying medical conditions that can impact how well an individual might tolerate a particular medicine or even potentially choose a particular medicine based on age, gender, presence of diabetes, blood pressure, cholesterol, or triglycerides and bone disease. And then also personal preferences. We'll come into this choice of agent, medication withdrawal decisions. So if you try to combine all of these up front or at any point in the continuum of care, you could see that there's probably 12 different iterations at any one point. And so I would say I've never seen two patients with AIH that look the same and got treated the same way. There's always something that's being done a little bit different. And the goals of treatment, I would say ideal goals are complete control. Of course, who doesn't want that? We all want to get perfect control. And that means normal enzymes, normal IgG, and also liver biopsy with no inflammation. The kicker is that not everyone can attain this endpoint, even after a few years of treatment. So I would say that from what I'm reading, it looks like 20 to 40% of patients actually achieve a complete biochemical and histologic remission. That's labs and biopsy. That's not to say that we don't get results from treatment. 80% of patients, if not more, will end up with some good control of AIH. And I would say the minimum criteria for a decent response would include these criteria depending on which studies you look at. They include the AST level less than 2 to 3 times the upper limit of normal, IgG less than 2 times the upper limit of normal. I would say that's a little generous, but that's what's out there. Having said that, folks that achieve these minimal criteria but not the ideal criteria are at increased risk of relapse if they withdraw medication. So it does say something about the underlying condition and the odds of being able to come off therapy if you cannot achieve a complete biochemical and histologic remission. And in terms of treatment failures, this is first go-around with standard therapy, which we'll talk about in a bit. 9% are treatment failures. That is to say they don't really normalize below 5 times upper limit of normal to 3 times upper limit of normal. And then incomplete responses are the in-between, so sort of hovering a little bit above that 2 to 3 line. And then we'll talk about some of the agents. So we sort of have an idea what we want to do, perhaps. And our choices are steroids and I would say everything else which is not steroids. And it's really a good way to kind of categorize these because steroids are what we use up front in high dose. They're very potent. They really do an excellent job at controlling the disease right now. That's what we want in a flare. We want to control it today, yesterday even, if we can. And we don't want to sit back and wait for some other medicines to kick in 6 weeks or 4 weeks or 5 weeks. So steroids really have that role up front in bringing disease under control right away. The problem with them, of course, you guys all know this, is bad side effects, and we'll talk about those as well. And that's where the not steroid group comes in helping us minimize the amount of steroids that we need, both potentially upfront and also in the long run, to achieve remission and maintain remission. And when we talk about steroids, the most notorious steroid in the West is prednisone, and in Europe it's prednisolone. Both are available both places, and the guidelines recommend different use, but they really are interchangeable for the most part. The other steroid I want to bring up is budesonide. Some of you may have heard about budesonide, some not perhaps, but budesonide is a steroid that is taken orally, just like prednisone. It's absorbed in the intestine and goes into the portal circulation, which feeds directly into the liver. And so in the liver, budesonide undergoes very high first-pass metabolism. What that means is 90% of budesonide that we ingest by mouth is metabolized in the liver before it makes it out into the main circulation and the rest of the body gets exposed to it. So the upshot is great exposure to the liver, minimal exposure to the rest of the body. That's beautiful. So it's a very attractive agent. It's been studied in patients with AIH who don't have cirrhosis, so not terribly advanced disease, and found to be as good, if not superior, because you can maintain higher doses of budesonide over the first 6 months of treatment, whereas prednisone, we start to taper back pretty quickly. So it's not a fair comparison with prednisone, but you get the idea. And we've got good experience of it with much lower metabolic risk profile than prednisone. So it's a very, very nice option to be aware of. The nut steroids group, the famous one is azathioprine, or 6-MP, 6-mercaptopurine. It's what we call an anti-metabolite. It inhibits DNA synthesis and lymphocyte replication, and really has been a stalwart in our arsenal for treating autoimmune hepatitis, for maintaining remission and helping minimize prednisone in the short term and long term. The other anti-metabolite out there is mycophenolate mofetil, which is also known as Cellcept. Some of you may have also have heard this. And I would say in our experience, that's probably number 2 agent if we have someone who can't tolerate azathioprine, although not a good idea to combine both because you're not likely to get additive immunosuppression, only additive toxicity probably. And then there are some other classes which are worth mentioning. The CNIs, never mind the calcium urine pathway, these 2 agents work through this particular pathway to inhibit the immune system. They're used very commonly in solid organ transplant. Tacrolimus is the main agent for use in most liver transplant programs in the country. Cyclosporin was the head honcho before Tacro came on board. And they've been studied in autoimmune hepatitis, but much smaller numbers, although they seem to be effective as second-line agents for steroid refractory AIH that has failed azathioprine or Cellcept in combination with steroids. And yet another group of agents is this mTOR inhibitor group. This is mammalian target of rapamycin. Big word, basically just another pathway that is vital for lymphocyte replication, clonal expansion of activated lymphocytes. So if you can suppress this pathway, you can really put a damper on the immune system. And we also use these agents in solid organ transplantation. They've got a slightly better side effect profile, which we'll talk about. Again, not much data in AIH, unfortunately, one small series in pediatric liver transplant recipients, but it is something that we've anecdotally used a fair bit of here historically. And then there are other agents that Dr. Lammert's going to be talking about later. In terms of treatment, I'm going to show you 2 graphs. The first graph, just focus on this side. So we make the diagnosis. We introduce some steroids, and we also introduce some azathioprine. The dosing varies a little bit between the US and Europe. We have to do some testing to see if that individual can metabolize thiopurines properly or not. And there are some interactions that we also pay attention to. And we look to see a response as we taper the steroids. When things don't go well, it looks a little bit like this. So we don't have 2 hours, so this is just complicated, and we customize. That's really the key thing from this slide. And so finally, sort of without getting into the difficult cases, I would say, well, what about monitoring the agents that we use? Steroids, there's really no dose adjustment. It's just set dosing, and we follow effect, and we just try to get off or lower the dose as much as we possibly can, as quickly as we can. And it's a bit of a game of chicken. You don't want to lower too soon, and the AIH flares, and you don't want to stay too long, and you get in trouble with the metabolic issues and other side effects. So again, customization is very personalized. Azathioprine, well, we do have some levels. There are some metabolites. 60G is the therapeutic component of azathioprine metabolism. And there's a sweet spot. We want to get it over 230 if we can. That's where you get the least chance of a relapse. But over 400, you're at increased risk of marrow toxicity. So when we check levels, for those that do check levels, we're looking to probably keep it in the mid-200s, less than 300 if we can help it. There are other metabolites, 6-MMP, which is toxic to the liver, particularly in high levels. And then finally, effect on lowering white cell counts is important. So we do follow white cell count as monitoring purposes. Mycophenolate does have measurable metabolites, but we don't really have a lot of data looking at outcomes based on metabolite levels. But in transplant, I would say there's good evidence building. Tacrolimus and cyclosporin. Sirolimus do have levels. We have data not only in AIH, but also in transplant that we extrapolate. It makes us feel good when we're trying to treat someone with AIH. We have some idea in terms of use in other patients who've had transplant at least. And then I would say special considerations. AIH and pregnancy, I think Dr. King discussed, so we won't touch it. Withdrawing treatment for AIH is important, and the role of liver transplantation. And Dr. Lacerda may have talked to some of you about this during lunch. So stopping treatment or treating indefinitely, that's probably a luxury question, because that means that patient has gotten to the point where they've achieved remission. And there are some pluses and minuses. One caveat is the drug-induced liver injury with AIH picture. That's a situation where there's a good chance that individual may not relapse after you withdraw treatment, because the AIH may have been induced, or in fact, it could be a drug injury that is looking like AIH. So we oftentimes try to withdraw treatment in patients with DILI and associated AIH. Here's the kicker. So you could see that there's a 20 to 80% chance of relapse after withdrawing treatment, and these are presumably selected patients, who have done well. So this is not very helpful, is it? There's a really good chance, or there's a really low chance you're going to relapse. So I would say it seems to be all over the place, but the key requirements would be not only biochemical, but also histologic remission. So if you've got those findings, I would say that most studies support that the risk of relapse is going to be on the lower side of these sort of gross and very broad estimates. But if you do relapse, particularly repeatedly, you probably are at a higher risk for developing poor outcomes. Although a quarter of patients with relapses can ultimately come off treatment, the vast majority are going to keep relapsing. And so if you relapse once, there's a good chance you're never going to do well with continued efforts at taking off treatment. And there's data to suggest that the on and off effect of treating flares, extended time to remission, and then coming off and retreating and sort of repeat the cycle over and over is actually associated with worse side effects from treatment than just maintaining remission with maintenance low-dose therapy in the long run. Another issue to customize. Transplant. AIH accounts for probably less than 5% of adult transplants, 2 to 3% of pediatric transplants. It's usually performed for individuals that have developed cirrhosis and have liver failure as a result, liver cancer, or acute liver failure. In transplant, it's multidisciplinary. There are multiple phases. There's the evaluation process, wait list period, where the priority for transplant is just based on labs. The transplant procedure itself, and then long-term follow-up and really living with transplant requires lifelong immunosuppression. And you see much the same agents that we talk about with autoimmune hepatitis. AIH does recur after transplant. There's a lot of variation in estimates of recurrence, 10 to 40%. But I would say it's probably better than 25% in most experiences. But having said that, we're able to control disease, and for the most part, losing the graft, i.e. needing another transplant or dying because of recurrent AIH is relatively uncommon, probably less than 10%, at least in our center. Side effects, steroids, I think you guys probably know this well. Cosmetic is very common, facial rounding, humps, acne, stria, which is red streaks on the belly, like stretch marks, facial hair. Weight gain is important, osteoporosis with pathologic fractures, diabetes, effects on mood and psychiatric conditions. Pancreatitis can develop early. Blood pressure, cholesterol, triglycerides, and not to mention infection risk and cancer risk, which is really an effect of immunosuppression in general, regardless of agent. With azathioprine, it's marrow suppression, so the concern for effect on white cells. Pancreatitis, nausea, vomiting can develop early on, but usually most patients will tolerate it. There is a risk of liver injury with azathioprine, I know. This can be a hepatitis, but also there's a long-term, relatively low risk of a sinusoidal obstruction syndrome and a risk of developing a condition called nodular regenerative hyperplasia. It's difficult to diagnose and fortunately rare. With Cellcept or mycophenolate, it's marrow suppression. There's a lot of GI side effects, nausea, vomiting, diarrhea, and it is a recognized teratogen, so risk of birth defects. So any female patients in birthing age have to be on dual birth control if they're going to use this agent. And then finally, these less commonly used agents with this class of medicine, the tacro, cyclosporin, it's renal disease, blood pressure, lipids, cholesterol, With sirolimus and everolimus, it's high lipids. There's some delayed wound healing, but it looks like these agents over here might have a bit of an advantage in terms of renal protection and maybe less in terms of blood pressure concerns, and certainly no effect on diabetes as tacro might. And then there are some global risks from just being on immunosuppression, particularly long-term, and these are infection, and it's really all over the place, but you can have some really odd infections and unusual infections, opportunistic infections, fungal, viral, TB, some really odd stuff, and you just have to have a low threshold of suspicion. Also, malignancy is a risk with lifelong immunosuppression. These are the estimates, 3% at 10 years. What this number here is the fold increase relative to a age and gender matched population. So being immunosuppressed with low-dose Imuran, for instance, gives a 1.4 fold increased risk of cancer. To put this in perspective, solid organ transplant patients, for instance, liver transplant patients, have a 2 to 3-fold increased risk of cancer. So I would say perhaps more immunosuppression equals higher risk. But if you think about your baseline risk of cancer, it's usually a small number. So even if you multiply it by 1.4, by 2, or by 3, you're still going to end up with a small number. Another analogy would be buying 3 lottery tickets versus 1. Yeah, you've tripled your risk, but it's still unlikely that you're going to get it. But I think the key point is not to ignore the risk and really sort of take it on and try to mitigate risk as much as we can. One quick word about risk of death. From one study, it's I believe a English study, they looked at 9 years out risk of death in patients who achieved remission, at least biochemically, at 1 year after treatment in 250 patients. And what they found is that around 12 patients actually had transplant or died from liver-related causes while waiting for transplant. Another 30 died from liver failure. So about a maybe 20% risk of bad liver endpoints at a 10-year time point. And the predictors of death in that group were patients who were older and had cirrhosis to begin with. So it's probably these are the risk factors. If you already have advanced disease at the get-go, you're at increased risk, and we know this. So the vast majority of people were alive, or if they died from non-liver-related problems. What's also important is, and I didn't put it there, is that the risk of non-liver-related mortality was the same compared to the average population. So the risk to someone with AIH, if they achieve remission in the long term, appears to be related to liver disease, not from the other things, not infection, not cancer, although we're never going to ignore them. And so what do we do to mitigate the risks of treatment? Well, vaccinations is important. We've got to keep up and vaccinate, even if we don't meet the age criteria. So anyone in immunosuppression, we would recommend flu shots annually, pneumonia vaccine, diphtheria, tetanus, pertussis, and keeping up with these on a regular basis. We have to pay attention to some of the metabolic risk factors that we talked about, looking at cholesterols, triglycerides, blood sugars, blood pressure, bone health, eyes, early risk of cataracts if there's long-term steroid use. And then in terms of cancer prevention and surveillance, skin cancer is a big one. It really goes up significantly in any situations of immunosuppression. UV protection is important, long sleeve shirt, hats, sun avoidance. Reducing risk factors for cancer in general, smoking and alcohol. Alcohol in particular in this combination are associated with foregut cancers, lung, pancreas, throat, oral. Safe sex, I say this for HPV, human papilloma virus, can be associated with cervical cancer. And so what we do is really just age-appropriate population screening guidelines. We don't do anything above and beyond what the average person does, with the exception of getting good skin sweeps on a regular basis, at least annually, if not every 6 months, if there is any hint of cancer or precancer. And then finally, if someone has cirrhosis of the liver, they're at risk for liver cancer. And so in addition to all these other surveillance strategies, we've got to do surveillance, image the liver intermittently for liver cancer. And so I think I went a little bit long. But striking a balance is the key. The immediate goals of treatment are to stop inflammation now, induce the remission as quickly as possible. Intermediate goals are to maintain this remission, long-term, withdraw versus maintain. Throughout all of this, what we want to do is use the minimum effective number and doses of agents to achieve and maintain remission. But at the end of the day, we have to always monitor for disease and medication side effects. And ultimately, it's really an individualized partnership and personalization of management every step of the way. Again, I've never seen two cases treated the same way. And with this, I thank you, and sorry I went a little bit long.